Now we're going to be talking about valve diseases. This is chapter 24 in your TIMBY medical surgical book. Valves are one-way doors to the chamber of the heart. A dysfunction occurs when the valve is unable to open or close. It is called stenosis when it's unable to fully open or if there's a narrowing. It's called insufficiency or regurgitation when it's unable to fully close. The two most common valves affected are your mitral and your aortic valves, mitral being the most common and aortic being the second. Look at it as your left side does more work because there's more blood being pumped out to all over the body, and your right side only has to pump to your lungs. So mitral valve, it causes obstruction to flow from the left atrium to the left ventricle or a regurgitation from the left ventricle into the left atrium. This causes the left atrium to dilate and hold the extra blood volume. In the aortic valve, it obstructs flow from the left ventricle to the aorta, or there's a regurgitation of blood back into the left ventricle. The left ventricle then dilates due to the increased blood volume. We'll talk about these a little more in detail as we go through. Aortic stenosis. So remember, what does stenosis mean? Remember we said it's that narrowing or the inability to fully open. So this is the narrowing of the opening in the aortic valve when the valve cusp becomes stiff and rigid. If you look over here in this picture, you can see the difference of what normal versus abnormal, the healthy versus the diseased valve. So it doesn't close or open all the way like a normal valve would. Going on to the little patho, what could be causing this? It could be an age-related degenerative change from progressive calcium deposits in your valve cells. In young adults, usually a later consequence of a congenital defect. Only 2 valves instead of 3. The same calcium deposits would make the symptoms show up faster. The stiff, calcified valve cannot open properly and it needs more force to push blood through its narrowed opening. So what happens to the left ventricle? More blood stays in, and the muscular wall enlarges and thickens. So here, this is the valve we're talking about right here. So if this looks like this and this, that means more blood is piling up right here because it's unable to get all the blood that's coming down to it out. So more blood is piling up here. Aortic regurgitation or insufficiency. This can also be called valvular incompetence. This is when the valve doesn't close tightly. So this can be a result from damage to the valve cusp or the papillary muscles. It can be associated with disorders such as rheumatic carditis, endocarditis, syphilis, or it could be an age-related stretching of the aorta. Normally the first sign of this is tachycardia. So again, let's look at what's happening in the heart. So blood leaks backwards. So here, this is what they're talking about. Blood leaks back. Remember, this is your left ventricle. So blood is leaking back down here into your left ventricle. This reduces your cardiac output and fluid overload in the left ventricle. So you have less output because you're having more fluid staying, more of your blood is staying in here. The left ventricle becomes chronically stretched, hindering the ability to pump. It also can cause the mitral valve to close early, which means if your mitral valve is closing early, that means your blood is going to be backed up into the lungs. And what's happening then is you're not getting enough oxygenated blood to supply the heart or the body. So at this point, you're having blood backing up in here. This could mean that your mitral valve is closing earlier, which means you're going to have a backup of blood into your lungs. So your mitral stenosis or insufficiency. Mitral stenosis is it obstructs blood flow from the left atrium to the left ventricle, meaning all the blood is not leaving the left atrium. The left ventricle is not being filled. It increases the left atrium pressure, so the atrium enlarges, blood flows back, creating pulmonary hypertension and edema. Some causes could be rheumatic carditis or endocarditis. Also have mitral regurgitation or insufficiency. Remember, the stenosis is the narrowing. Regurgitation or insufficiency means it's not closing completely. This can occur with mitral valve prolapse or stenosis. Backflow to the left atrium, increased pressure to the left atrium and left ventricle, causing the dilation. So here, mitral stenosis, blood is setting, so it can lead to a clot formation. With both of these, you can hear a murmur. A mitral valve prolapse is when the valve cusp enlarge, becoming floppy, and bulge backward into the left atrium. The cause is unknown, but it is more common in young women, and many require no treatment. With your tricuspid and pulmonic valves, this is blood flow from the right atrium is obstructed back and into the systemic circulation, meaning that instead of going to the lungs when you have tricuspid or pulmonic valve disorders, your blood is backing up into your body. So you will see more signs of bodily edema rather than the respiratory issues. Some common risk factors for valvular disorders would be rheumatic fever, congenital heart diseases, syphilis, endocarditis, and hypertension. Signs and symptoms, they can be asymptomatic. Often an opening snap is heard when auscultating heart sounds. They can have an irregular heart rate. You could have extra heart sounds. They can be tachycardia. You could have palpitations and you could hear murmurs. Some other signs and symptoms would be fatigue, dyspnea, pulmonary edema, angina, and dizziness. Breaking down each of the individual aortic stenosis, they're going to have more of the dizziness, fainting, angina. At first, they may experience dyspnea and fatigue during activity. The carotid pulse will be weakened. You could hear the S2 heart sounds. The S2 heart sounds would be split because the aortic and the pulmonic valve are at closing at different times. Remember, normally they close at the same time, but when you have the aortic stenosis, they will be closing at different times. With aortic regurgitation, tachycardia would be your first sign. You could have palpitations, dyspnea, chest pain. Their skin could be flushed and moist. They could have a very strong and quick sharp beats followed by a sudden collapse of force. That could be, you could hear murmurs. Mitral stenosis, they can be fatigue, dyspnea, you can hear heart palpitations, crackles, and murmurs. With mitral regurgitation, the S1 sound diminishes. They can have chronic fatigue, dyspnea on exertion, palpitations, and murmurs. Diagnostic test, you could have a chest x-ray, echocardiogram, electrocardiogram, and a cardiac cath. Non-pharmacological treatment, we want to tell them to limit exercising, rest with activities, stress reduction and coping strategies. We want to see, can we help them reduce their stress and how to handle those stressful situations with coping strategies. We also want to limit their sodium intake. Pharmacological treatment, we could do anticoagulants, beta blockers, nitroglycerin, and most of these are going to be on lifelong antibiotics prophylactically. Bigger surgical management would be the leaflet separation, which is a transcatheter valve replacement. It is shown on page 403 in figure 24.3. You can also have valve replacements. These can be a mechanical, human, or an animal. They usually would use a pig or a cow. Some other ones would be percutaneous balloon valvuloplasty, which is a non-surgical balloon is placed between the left and the right atrium, which allows blood to shunt to the right atrium to relieve some of the pressure. What would we need to do? We would monitor their EKG patterns, implement teaching plan on prophylactic antibiotic therapy, prepare the client for surgical repair and placement, talk about anticoagulant therapy, and look at biological valves that do not require biological valves do not require lifelong anticoagulant therapy. So looking at all the options that they have.